All right, well, I've got 2 o'clock, so I'm going to go ahead and get us launched. Good afternoon, everyone. I'm Don Neese. I'm in the Department of Family Medicine here at University of Colorado. And it's really my pleasure and honor to moderate this session on health equity and mental health. And we'll be diving deeply into some things. We've got some great panelists here. Dr. Renee Johnson, who's at the Johns Hopkins Bloomberg School of Public Health. Dr. Renesa Anthony at UC Berkeley, also with affiliations with Momentum Park and Womentum MD. Dr. Steve Wolf from Virginia Commonwealth University, and I've got the anchor position here from our University of Colorado Anschutz Medical Campus. Just a reminder for everyone to go ahead and mute yourselves. You're welcome to chat questions into the chat box as we move along with the presentations. We'll have time for about 15 minutes at the end for questions and answers and hopefully some discussion. So without further ado, I'm going to pass the baton on to Dr. Johnson.
Okay, I'll work on sharing my screen, which should be shared now, and start my video. So you should be able to see me now. And okay, I will begin my presentation. Hello, everyone, and thanks for that introduction. I'm talking about race, ethnicity, adversity, and behavioral health among Maryland adolescents. I have no conflicts of interest and am happy to acknowledge funding, collaborators, and others who made this research possible. So, emotional and behavioral problems among adolescents are increasingly viewed as a response to trauma and adversity. It therefore makes sense to have a clear understanding of how many youth experience adverse experiences. So let me pose a question to you all. How do you think we're doing with regard to surveillance and assessment of adolescent emotional and behavioral problems? Now, how do you think we're doing with regard to adolescents' traumatic and adverse experiences? Think about where you work. How quickly could you get a prevalence estimate for current alcohol use among youth? And how about an estimate of the number of adolescents who have a parent with a substance use problem? In most places, learning about behavioral problems is easy, and learning about adverse experiences is quite difficult. So I'd say that we're doing a good job assessing problems, but a poor job of assessing adversities that shape risk for those problems. So part of the problem is that local, state, and national adolescent health surveillance programs have not historically assessed adverse experiences. And this was the case for my home state of Maryland until recently. In response to youth advocates citing the critical importance of adverse childhood experiences, or ACEs, the Maryland Youth Risk Behavior Survey included items on adversity for the first time in 2018. So today I'll report on some of that Maryland YRBS data. In particular, I'll estimate the prevalence of ACEs among high school students in Maryland, and I'll provide associations between ACEs and behavioral problems. Those of you who study ACEs probably have a much more precise way of measuring them. So this is definitely surveillance type measurement done on the ground, shoe leather assessment, if you will. The purpose of the Maryland YRBS, the Maryland YRBS is a large statewide school-based survey of public high school students with the purpose of assessing risks and health behaviors. It's administered on a biennial basis by the Maryland State Department of Education and the Department of Health in conjunction with 2 CDC programs, the Youth Risk Behavior Surveillance System and the Youth Tobacco Survey. To build the sample, Maryland Department of Health used a multi-stage cluster sampling design. The response rate was above 60% for each individual county and for the state as a whole. A copy of the data collection instrument is available at the CDC website. The variables I explored to represent problems include emotional distress, poor school performance, past year suicidal ideation, any past year fighting at school, any past 30-day alcohol use, and any past 30-day marijuana use. Additional variables include grade level, race and Hispanic Latino ethnicity, sex, and county. And some classification variables included grade, race, it's hard to have so many screens and do this. Okay, so there were 5 items on adversity, including caregiver verbal abuse, food insecurity, substance use or gambling, mental illness, and criminal justice system involvement. I created a 6th variable to represent multiple ACEs, and the categories were 0 of the 5 ACEs, any one of the 5 ACEs, 2 of the 5 ACEs, or 3 to 5 of those ACEs. So, as you can see from this table, the prevalence of ACEs was high. 29.2% reported family mental illness, 23.7% reported parental gambling or substance use, 23.5% had a family member who had been in prison or jail, 20.3% reported caregiver verbal abuse, and 16.9% reported food insecurity. More than 1/2 of the respondents, these 3 rows right here, reported at least one of the 5 ACEs. 1/4, 25.8% reported just one of the 5 ACEs, 15.1% reported 2, and 15.4% reported 3 or more. We used multivariable logistic regression analyses to assess associations between each ACE and each emotional behavioral problem, adjusting for race, ethnicity, sex, grade level, and sampling design. As expected, the ACEs were strongly associated with behavioral problems. I've included just 3 of the ACEs here for simplicity. And as you can see from the first column, those who reported that a family member had been to prison or jail were more than 75% times more likely, more than 75% more likely to report each of these 5 behavioral problems. Consistent with studies linking, these findings are consistent with studies linking parental incarceration to child outcomes. So as you can see here, young people who reported a family member has been to prison or jail were 2.04 times more likely to report poor school performance, 2.04 times more likely to report emotional distress, 2.06 times more likely to report suicidal ideation, 2.59 times more likely to report fighting at school, 1.7 times more likely to report any past 30-day alcohol use, and 2.69 times more likely to report past 30-day marijuana use. So with all of that as background, I'm going to now tie in what I've presented so far back to the theme of equity. Emotional and behavioral problems that we've already been talking about, like depression, poor school performance, substance use, these impact the life course for adolescents and jeopardize their transition to emerging adulthood. So as professionals focused on adolescent health, we want to prevent and reduce emotional and behavioral problems. Ongoing work, including what I've presented today, shows that adverse experiences greatly increase the risk for emotional and behavioral problems. So the next question could be, how are adverse experiences distributed in the population? Answering this question will offer clues about the social and structural determinants of adverse experiences. So to explore this question, I examined differences in the prevalence of adverse experiences by race ethnicity. This slide shows the prevalence of each ACE and multiple ACEs by race ethnicity And the main take-home message is that ACEs are differentially distributed by race. Race ethnicity groups are indicated by colors. White equals red, Black equals orange, Latinx equals green, Asian equals purple, multiracial equals blue, and all other groups equal yellow. There were statistically significant race ethnicity differences in the prevalence of each ACE and in the number of ACEs. And within race groups, the prevalence of each ACE varied. The most common ACE for Black students was having a family member who had been to prison or jail, whereas for white students, it was mental illness of a family member. Asian students were less likely than those in all the other groups to report ACEs or multiple ACEs. So this figure is fascinating, but it's really hard to digest. So I'm just going to take a piece of it and we can talk a little bit more in detail. I'm just going to focus on one ACE, and that's having a family member who had been to prison or jail. This was the most common ACE for Black students and the second most common ACE for multiracial students. Nearly 2/3 of those multiracial students indicated that they were Black and another race. So Black, white multiracial, Black, Asian multiracial, or Black American Indian multiracial. The Maryland YRBS data showed that more than 1/4 of Black, multiracial, and Latinx youth reported a family member had been to prison or jail. We know that this is an adverse experience that nearly doubles the risk for many emotional and behavioral problems. Race ethnicity differences in the family member involvement in the criminal justice system is almost certainly tied to race-based disparities in the criminal justice system. Thus, now we have the opportunity to look at structural factors that shape risk for adverse experiences that in turn shape risk for emotional and behavioral problems. Black Americans make up 40% of the incarcerated population, despite representing only 13% of the US population. You can see from this figure that the 1 in 3 Black men, the likelihood of imprisonment is 1 in 3 for Black men. Incarceration impacts families, and it's critical for understanding adolescent behavioral health. So in summary, we found that Maryland high school students with a family member who had been to prison or jail are more likely to report emotional and behavioral problems. And this is consistent with studies linking parental incarceration to child outcomes. 2, we observed that more than 1/4 of Black and or Latinx students reported having a family member who had been to prison or jail. And 3, we estimated race ethnicity differences in ACEs because we know that marginalization and structural racism shape the distribution of ACEs among youth. Our results suggest that criminal justice system policies and practices are a structural determinant of emotional and behavioral problems among adolescents, especially among Black and Latinx youth. So how does this relate to health equity? LaBerge and colleagues suggest that health equity means everyone has the opportunity to attain their full health potential, and that no one is disadvantaged from achieving this potential because of their social position or other socially determined circumstances. Further, they recommend defining pathways and processes through which influences of structural determinants of health inequity are transmitted and patterned. So based on their framework, equitable approaches to adolescent health promotion require ensuring that health and well-being within the context of a racialized criminal justice system. I'm sorry, that doesn't make sense. An equitable approach requires ensuring the health and well-being within the context of a racialized criminal justice system. This means that our programs need to address the adverse effects of family involvement in criminal justice in the programs. And we've seen this with other programs like military connected families. So we know that if you address the unique stressors of young people with parents in the military, that the prevention programs are a bit better. And then my second and final recommendation is to address the structural factors. So you supplement prevention programs. And this is really moving upstream. So we should be thinking about criminal justice policy. So what I want, I'm out of time. What I want you to take away from this talk is that just by including items on adversity in surveillance, we change the conversation about adolescent health behaviors and now can produce data to build the evidence base for addressing upstream factors. Thank you.
All right, thanks so much, Dr. Johnson, and we'll move on to Dr. Anthony.
Thank you. Thank you for the invitation to be a part of this important work. I consider this my soul work. I share my screen here. Share screen, my presentation. Okay, this is all new for us. Okay, can you see? Don?
Not yet.
Not yet, okay. Let's try again, share screen and share.
There we go.
Now, beginning.
Perfect.
Okay. So thank you again for this opportunity to present really important work that I'm passionate about. I consider this my soul work. And I'll be presenting on It Matters, Black women's mental health and the unique perspectives related to that. And this is very timely. These are unprecedented times, whether we're talking about COVID or Black Lives Matter and civil unrest in our country, police brutality. We have fires out where I live in California, hurricanes happening in the South, and we're in the middle of an election year. So 2020 has been unlike any other, and it's impacting a lot of our health and our mental health especially. And in years to come, when we look retrospectively, we'll understand a little bit more how it impacted different groups. But let us not forget, even though from an African-American perspective, this is not new. We have a long-standing history when it comes to marginalization, discrimination, and in 2020, it's taking a new resurgence in the way that it's being addressed. So we came for a quick history lesson as slaves to this country for hundreds of years. We worked in fields from that perspective. And it's not the first time that we've seen mothers wailing and crying. If you don't know who this is Emmett Till's mom, Mamie Till, and he was a little boy from Chicago who went to visit his family down south, and the questions remain whether he whistled at a white woman store owner or not, but basically two white men kidnapped him and brutally murdered him. And to this day, they have no one has ever been charged with his murder, but his mother made a decision to have an open casket for his funeral. And it drove thousands and thousands of people to be able to see where our country was at that time. And so we've been in this long-standing history of racial equality, and here we are in 2020 with a resurgence and a different way of approaching this that still is yet to be seen. And how this impacts our mental health, it varies. And if you can imagine, when you look at academics and those who do research, those who represent this sector who can come from a culturally competent perspective has been far and few between, and that also has to do with our history in this country. So overall, mental health is an essential component of health and well-being. I love that term well-being, and I love that it's showing up in things like Healthy People 2030. And we know that there are significant racial ethnic disparities that exist regarding not just the incidence of mental health, but the prevalence, the diagnosis, the treatment, access to care, and even the acceptability of mental health conditions and the utilization of services in the African-American community. And now more than ever, we need these culturally competent, relevant mental health services and providers. If you look at the National Alliance on Mental Illness, they recently released a comment about what's going on in this country. And I don't want to read to you, but I would like to bring to your attention that racism and racial trauma on mental health is real and cannot be ignored. And our nation's African American community is going through an extremely painful experience, pain that has been inflicted upon this community repeatedly throughout history. And it is magnified by mass media and repeated deaths. NAMI stands with all the families, friends, and communities who have lost loved ones senselessly due to racism, and with more than 100,000 lives lost to the coronavirus. So I wanted to bring this to your attention because this was published in May, and here we are now in October, and that number has more than doubled. This year, when we look at mental health services, it's important to also understand that there are gender differences, not just racial differences. And so long-term, there has been stigma, there have been lots of different issues when we look at just African Americans, but I would bring to your attention, it's also important to look at gender differences. The experiences of African American men and African American women have their unique intricacies that need to be considered with treatment, diagnosis, intervention, support, and as well as research. Mental health among African American women. This was published on Hopkins by Dr. Richards. And she states that part of the challenge in getting care is the cultural belief that only people who are crazy or weak see mental health professionals. There's a feeling in a lot of Black communities that women have to be strong and stoic. Women are so busy taking care of everyone else, their partners, their elderly parents, and their children, that they don't take care of themselves. However, women should be reminded that attending to their own needs, whether physical or emotional, doesn't make you weak. It makes you better able to care for your loved ones in the long run. Also, my colleague, Dr. Woods Gibson, really brought this to the forefront about a decade ago when she started talking about the Superwoman schema and African American women's views on stress, strength, and health. And as a BIPOC woman, Black, Indigenous, and person of color, I have been able and afforded to live across multiple socioeconomic groups, multiple racial groups. And when I think about it, I can't bring up any other group where it is, or you hear you're a strong Black woman, or it's an accolade to be strong. And over time, being strong over and over and over and carrying this burden is shutting Black women down. And so the foundations of the Superwoman schema has 5 elements: these obligations to present an image of strength, that nothing bothers us. I saw it from my grandmother, I saw it in my mother, I see it in my aunts. It's a generational transference of this. And if you think about our history, in some ways you can understand when you had to deal with things like slavery, deal with your children being sold off in front of you, dealing with the children's father being beat in front of you over time. Being strong and mentally as strong is something that you had to do. And then it's been passed down in story and experience over time. And so I grew up hearing about the importance of being a strong woman and how strong my grandmothers and my aunts were. But at the end of the day, what Dr. Gibson has been able to show is that now in the 21st century, that definitely is causing additional issues and challenges because some of the challenges and issues have changed. Number 2 is really this idea to suppress emotions. So I'm strong, I'm fine, I'm just gonna pray on it. Nothing gets to me, I'll talk to God about it. 3, this resistance to being vulnerable. 4, the strive to succeed despite limited resources. And 5, feeling obligated to help others and be self-sacrificial. So those are the characteristics. And if you think about the contextual factors here, this historical legacy is really important. And it's really important when counseling or providing therapeutic services or interventions for African American women, that to treat holistically that woman and the person, you have to consider the entire life course and the generational course as well. We learn these lessons from our foremothers, from histories of disappointment, mistreatment, or abuse, and also spiritual values. So you can imagine being a mother to a Black son in 2020, but can you imagine in 1950 and 1900? Those stories have continued to be the same as to how you respect the police, how you respond, how mothers pray and think about the outcomes for their sons at any given time, because how they're viewed and treated in the world based just on their color. The perceived benefits of having this is really around self-survival and preservation of the community and the family. And then unfortunately, the liabilities are these strains in interpersonal relationships, these stress-related health behaviors. And at the end of the day, what we're talking about now is really mental health, these presentations of anxiety, depressive symptoms, and adverse maternal health outcomes, which is where my passion lies. There are unique cultural and gender specific needs. Many of these areas deserve and warrant additional research and study. We are the only community in the United States that happens to be a matriarch that has a historical component that I don't have time to talk about. Religion is a huge component in the African American community, which is why a lot of the interventions in the 90s and early 2000s really focused on these faith-based initiatives. Stigma is a huge issue, and I talked a little bit about why that exists. Domestic intimate partner violence, all of these things, if you look at them, the incidence and prevalence is a lot higher. Some of the unique intricacies are different, especially when it comes to like work-life balance, imposter syndrome. It is known that a lot of times grandparents are raising children. There's something called baby daddy drama and how that plays out. Also, in the past year to 5 years, social media and witnessing our people being shot, being killed, being discriminated against, what that does to someone consciously, how that impacts mental health, is almost to the point of exhaustion where I just won't look at them anymore. But what does that mean as well? My partner and my colleague, Dr. Renee, also talked about incarceration, and that was one of the main issues when you looked at ACEs for Maryland African-American students, but that's real in families, taking care of elderly parents, because culturally putting your parents and family members in senior housing and living is taboo and has stigma as well attached to it. And then there are lots of generational cycles attached to different things. And now attack all of that and put on top of it COVID-19, and knowing that there's a significant disparity between African Americans, minorities, and their outcomes, which death is much higher with COVID-19. And then this whole idea of family matters and this silence. So in addition to stigma, there's this cultural belief that what happens in this family stays in this family, and you do not tell other people our business. So a lot of different unique cultural and gender specific ideologies that have to be considered when you're creating interventions and when you're treating this population or serving this population. So how does it impact my soul work and passion? I am passionate about mamas and babies, all mamas and babies. But from my standpoint, we know that all women could use help during pregnancy. And we really focus our efforts at Momentum Park on helping women who need help the most. And so that happens to be women of color and rural women. And all of this comes down to, what do you think of? And when I think of and say to you, African-American pregnant woman, what comes to mind? And unfortunately, we know that there are differences when it comes to disparities in pregnancy and birth outcomes. So all of these things listed here, they are higher in African-American women. And we know that this doesn't just happen by happenstance. There's a life course perspective from the time that we're born. And if you look at Dr. Liu's work, it's really preconception. So before we are born, these generational pieces. But depending on what family you're born into, there's so many things, from whether or not you're breastfed or not, or bottle fed, what kind of fruits and vegetables or healthy foods you get access to, where you actually go to high school or school. That difference there makes a huge difference. Where you live and your zip code. We know that all of these impact health outcomes, and long-term, as my colleague talked about, these ACE scores that start early in life have a long-term impact on your health outcomes and birth outcomes. So what happens to that mom long before she becomes pregnant also impacts her children. And that's why I invest my time in mamas and babies, because I feel like healthy moms have healthier babies have a healthier long-term outcome. So solving the problem through Momentum Park, where moms come first and every moment matters, we didn't want to focus on the problem anymore. We really wanted to focus on the solution. And the solution is improving the health and lives and well-being of moms and babies across the life course. And we do this with an equity lens. And I love this here because this shows the difference between equality versus equity. And we usually had these two slides, and then now it's, instead of like giving equal resources or giving more resources, it's really looking beyond and how do you remove the fence in the first place so everyone gets an opportunity to see. Also having work on our interventions that are focused from a trauma-informed lens and changing the question from what's wrong with you to what happened to you. And I named and listed a lot of the things that are the problem in the community, but there's also positive deviance. And really in every community, there are individuals and groups that thrive. And studying those groups are really important because what's wrong is always available, but what's right is also available too. So we tend to look at what are the community assets and how can we learn from those. So our contribution was, I started a nonprofit organization called Momentum Park, where moms come first and every moment matters. And we launched August 2020. So I'm super excited about that. And last year, this came about because we wanted to get information from the people. So in 2019, over 5 days, we went to 2 major conferences that bring a huge amount of African Americans. And we wanted to make sure that we had men involved as well. So we went to the Essence Festival, as well as the 100 Black Men Leadership Conference in Las Vegas. And our only incentive was a $2 bill. We recruited almost 1,200 people. I used racially concordant groups to recruit folks. We made it electronic on a cell phone. And basically, as you can see here, it took 5 to 10 minutes to do. We had our own dedicated space, and this was our sample across the US. And basically, we were able to recruit a generalizable sample of where most African Americans live in the United States. And we asked questions about infant mortality and maternal mortality. And as you can see, most people of African American descent recognize that it is a problem for us. And then we also assessed experiences of racism and discrimination. So how many times have you personally experienced this? And then how many times do you think about your race and ethnicity? We also wanted to know about people's use of technology and if technology could potentially be a solution to adverse pregnancy and birth outcomes. And what we both saw was that African Americans were open to telemedicine, which thanks to 2020, that's now something that everybody knows about and is using. And then we also asked specifically about technology, device, apps, and products, if they thought it could improve the lives and well-being of moms and babies, and majority felt yes. So data, I only believe, matters if it makes a difference, and that required an ecosystem shift. So all my work has been in healthcare, medicine, public health, and policy, and in 2019 really started to shift and add this new component of technology. My team and I, we just created the SHERO program, Shaping Healthy Empowered Reproductive Outcomes. And this is to really address the complexities with African-American women, especially during pregnancy. So we've created this small pregnancy pods of 8 to 12 moms that's modeled off of the ideal centering of pregnancy group. It's led by Black, Indigenous women of color, health professionals, and then it's connected to an online ecosystem. And that ecosystem provides the mental health services, as well as pregnancy services, what to expect when you're expecting, but most importantly, provides a community that no longer exists during pregnancy because of COVID-19. So during pregnancy now, you can only go alone until you go into labor, and then you can only have one person there during your delivery. A lot of things have changed with the way that we do prenatal care, and that's really impacted community for women and centering in person. So we've created that on an online ecosystem for women. And our goal and what we hope over the next 5 years is to bring in thousands of babies that come through our SHERO program and have healthy moms and result in healthy babies. And of course, through that, collecting a lot of data to influence what works and what doesn't. So Black women's mental health matters, and it matters from a life course perspective, especially as my colleagues started to talk about with ACEs. These experiences, risk factors, promoting factors start so early in life that we want to be able to think about women's health across the life course and those intricacies and unique perspectives. And I'll end by just holding a 3-second of silence for another BIPOC health provider, Breonna Taylor, who was shot and killed in her own home on March 13th, 2020. Thank you so much. And with that, I'll turn it back to Dawn.
Thanks so much. Very powerful. Let's move on then to Dr. Wolf. Steve, you need to unmute yourself.
Okay, there we go. And let me just get my slideshow started and I'll be good to go. That was amazing. I really enjoyed both presentations. And I hope we can talk more about it during the Q&A. The last two presentations have been focusing on inequities at the population level by race, ethnicity, by sex and gender. And we can also think about inequities in terms of geography. And that's what I'm going to be talking about, with a focus on what might be called stress-related conditions. To back up for a second, big picture, life expectancy in the United States has not kept pace with advances in other OECD countries. In fact, in the last few years, we've been seeing a decrease in US life expectancy while it has continued to climb in other countries. And of course, it's going to worsen further because of COVID. But when we think about what's responsible for this change in our life expectancy since the 1990s, research shows that it has a lot to do with a change in death rates during the working age population. So folks ages 25 to 64. In general, for young adults, children, teens, we see mortality going in the correct direction and declining. Same for older adults in the United States. But as you can see in this graph, mortality rates for people in the middle age group, 25 to 64, have basically done a 180, and as of 2010 have been increasing. And this increase actually hides cause-specific increases in mortality. This is looking at all-cause mortality, but death rates from specific causes of death, like drug overdoses and others that we will talk about, began increasing in the 1990s. They were offset to some extent by advances in medical care that reduced our death rates from HIV, ischemic heart disease, and cancer. But eventually, the number of deaths from these other causes grew to be so great that they tipped the scales. And as of 2010, we're now seeing an increase in midlife mortality. A few years ago, media coverage of this phenomenon made it seem like this was a uniquely white experience. The increase in mortality rate was first observed in the white population, but subsequent research has shown that the increase is actually occurring across racial and ethnic groups. Let me walk you through this infographic a little bit. This graph is showing you, where I'm moving my cursor, how this age group's mortality rate has changed across different racial and ethnic groups. And indeed, you can see for the white population, a roughly 9% increase between the mortality rate in the 1990s, in 2010, and what we have now. If you look at the Black population, you see a very positive trend that has been occurring since the 1990s that has lowered the mortality rate for African Americans and helped close, to some degree, the Black and white mortality gap. However, as of 2014 or so, this too took a 180 and mortality rates began to climb. And note the actual absolute rate, 510 deaths per 100,000 versus the white mortality rate of 357 per 100,000. So even with the progress that's been made in lowering Black mortality, and even with the media attention to the increase in white mortality, the huge disparity between African Americans and whites persists, as it has for many generations. Also in the Hispanic population, we've seen an increase in mortality, a huge increase in the Native American population, and even in Asian and Pacific Islanders, who as a group tend to have better health than whites. we are also seeing an increase in mortality rates. So what's responsible for these excess deaths? In an analysis that we published in the British Medical Journal in 2018, we showed that a large chunk of that is due to what demographers call external causes, drug overdoses, suicides, alcohol intoxication, binge drinking. However, there was also a big contribution from organ diseases, diseases of the heart, digestive system, lungs, and so forth, also contributed to increasing death rates in this age group. And mental and behavioral causes as a separate cause of death were also contributory. If we break this down by cause of death, you'll see that for the 25 to 34 age group, this line, which is drug overdoses, stands out as a major cause of the increase in mortality. But as you get older and look at older populations, you see the contribution of a variety of chronic diseases as well as those conditions. Now, I talked about geography, and what I'm going to share with you very briefly is some work we did initially looking at the increase in white mortality. This was funded by the California Endowment, which obviously wanted us to look at California, but also supported us in replicating the study in other states. And what we found, I'll get to in a second, in all of these states, large increases in deaths from accidental drug overdoses, and each of these lines represent one of the 5 states that we focused on. Increases in deaths from alcoholic liver disease, increases in deaths from alcohol poisoning, increases in deaths from suicides. Some people call these deaths of despair. We can talk more about it, but for our purposes, we called them stress-related conditions. And when we mapped where within each of these states this increase was most concentrated, we ended up with results like this. We can talk more during the Q&A about what we learned from this, but in general, the pattern was, at least for white mortality, that the increase in deaths in this age group was concentrated in areas that had dealt with social and economic stresses for some years. So in California, it was the northern timber country in the Central Valley. In Virginia, it was the southwestern coal fields. And similar trends, the Ozarks in Missouri. These are all places that experience more concentrated increases in midlife mortality, but are also places that have really been hit hard for many years by changes in our economy that have put jobs at risk. We have developed a composite index in the state of Virginia for measuring behavioral health. This was done for our community service boards, which are the entities that provide mental health care to the different jurisdictions of the state. And what we were able to do by developing this composite index, which in this case is describing the percentage of the population reporting mentally unhealthy days, is again help to locate where in the state the needs were greatest, so that this could inform decisions about what resources and budgets to allocate to the different CSBs or community service boards in the state. We were able to create a histogram like this, which allowed each of the jurisdictions to see their index. And as you can see, there was quite a difference. And in this particular index, the lower the score, the worse mental health. So I'm going to stop there, hopefully catching up on some of our time. And I really look forward to the Q&A because those are some really interesting presentations.
All right, thanks, Steve. And as I mentioned, I've got the anchor spot here, so I'm going to bring up my slides. There we go. Hopefully that's coming across. So again, really great to be a part of this fantastic panel. I'm going to talk a little bit about work that we've done at the local community level here in Colorado to address mental, emotional, and behavioral health issues with an equity lens as well. As I mentioned, I'm in the Department of Family Medicine here, where I'm Vice Chair for Community, and I also direct our Community Engagement Core with our Clinical and Translational Sciences Institute. So just a little bit of orientation about Colorado for those of you that aren't from Colorado. So Colorado sometimes can be thought of as being fairly white, but we actually have significant amounts of diversity within the state. This map that I'm showing just maps out at a county level. As far as shading goes, the percent people of color in those different counties. And you can see particularly in the south central areas of Colorado, significant proportions, largely of Hispanic folks in those areas, some that have actually been there for many, many generations. We also have, just in our own backyard here in Aurora, we have one of the most diverse communities in the country. I think last I heard in the high school and in the school system in Aurora, there's over 100 native languages represented amongst the student bodies there. And even in rural Northeast Colorado, you'll see Morgan County up there that has a large and diverse population that includes Somali immigrants and others that work in the meatpacking industry in that particular county. The other thing that I'll point out here is the dots. The dots represent places where we have partnering PBRN practices and across the state of Colorado as part of our SNOCAP practice-based research network infrastructure. Those practices are embedded in those communities, and we really consider this to be a practice and community-based research network. And the photo on the right just shows some windshield time down in the San Luis Valley, down in that south central part of Colorado, a beautiful part of our state. So one of the things that we regularly do as a part of our work is we try to figure out what are the priorities for the communities and practices that we work in. And this is a table that was part of a paper that we published last fall, just kind of reviewing how we do our priority setting sessions within SNOCAP and some of the topics that have emerged. And the striking thing here, I think, is just how many times since 2015, mental health has arisen as a priority topic for our communities and practices. You'll see mental health in the judicial system back in 2015, diabetes, obesity, and mental health in 2016, adult and adolescent behavioral health access in 2017, social isolation, loneliness in 2018, primary care team burnout in 2018. So this has been really top of mind for us over the past years and trying to figure out ways that we can work with communities to address these issues. So this afternoon, I'm going to talk about a couple of different methods that we've used in our work, and finally a project that we've used to address this topic. And here in this picture, you see one of our community groups that we pulled together to work on opioid-related stuff in the San Luis Valley. So one of the methods that we use a lot is something called bootcamp translation. And bootcamp translation, we've done now probably close to 40 of these around the state. We've done trainings, just completed one last week for folks in Michigan, Texas, and Nevada in this methodology. Bootcamp translation takes evidence in the form of guidelines coming from evidence from randomized controlled trials and other places, and engages communities in translating the jargon, the scientific language, into locally relevant messages and materials. So an example of that, the very first bootcamp translation was focused on screening for colorectal cancer. So the way the community changed that in Northeast Colorado was to change it from screening to testing, and from colorectal to colon cancer, and a whole variety of other things that the community creatively came up to really get the message out about the importance of screening. This typically is a 6 to 8 month process that creates distribution-ready products, and we've seen success in changing attitudes, knowledge, and really driving behaviors across a huge number of topics, including mental health. Well, what do you do if you don't have any evidence on the shelf? And here's where we've brought in appreciative inquiry. And this goes back to this notion of positive deviance that was mentioned earlier. And people are generally, there's a subset of people in communities that figure out ways to navigate these issues. And we did this in a couple of our communities, both our urban 2040 Partners for Health community here in Denver and Aurora, and also in rural Eastern Colorado, specifically looking at the question of how do people with mental health symptoms get connected to care. Fascinating information that really highlighted the importance of family members, friends that act as advocates for people to help them realize they're having struggles, help them get into care. So that's been a really useful methodology for us, and would love to talk more about that if folks are interested. Finally, here I'm going to talk about a project called Upstream Together. This was a project funded by the Colorado Health Foundation. It began now, I want to say, roughly 4 years ago. And we used it to engage 3 Colorado communities to develop approaches to prevent mental, emotional, and behavioral health issues. Boot camp translation was actually integral to the work. We used that as a method to pull folks together to educate community members about what was going on related to mental, emotional, behavioral health in their communities, and then to develop approaches that would help drive community awareness. There's ongoing work that continues in 2 of these communities, in the San Luis Valley and Alamosa, and also in Northeast Colorado. As I mentioned, for Upstream, we used bootcamp translation to learn about the evidence-based strategies and health information around MEB problems, create a set of messages and materials to get the concept of prevention out to the community, increasing awareness, changing attitudes, motivating and identifying actions. In each of the communities, they identified a focus area to support prevention of these problems and to lay the groundwork for long-term program development. And they each prepared practical plans for evaluation of the implementation and the effect of the resulting interventions. So I'm going to highlight a couple of these. First of all, in Alamosa in South Central Colorado in the San Luis Valley, their intervention were these boxes that they called MEB boxes. These were designed as table toppers. And here you see one at a local restaurant in Alamosa. And the idea was to use these to stimulate conversation about mental health. You can't really see it here very well, but the notion was that particularly at a restaurant or around the dinner table at home, you could open up the top flap, drop your cell phones in so that you weren't distracted by your cell phones, and talk about the issues on this box. And around the perimeter, there were a number of facts. There were like quiz questions with answers on the bottom of the box. And these were produced in 3 different versions: a restaurant version, which you see here, a version that was designed to be placed in homes, and we used churches and other kinds of venues to get those distributed into homes. And then finally, a school-based version that was designed to go into lunchrooms and at the college campus of Adams State in Alamosa. Each of these also had a Spanish language version. So as I mentioned, we had evaluation built into this. So we did some community-based surveys to see what the response was, and people thought this was very interesting. They liked it. It was successful at stimulating conversations. Um, People felt like they learned something. There was some buy-in to the fact that it got tables talking about these issues, raised some questions, and I love the last one. 3% they found some humor in this, so that was really interesting. So what's going on now with this group? So they've rebranded themselves a bit. They now call themselves Alamosa Voices. The group continues to work. We worked with them to say, okay, what's next? And we looked at a host of evidence-based interventions. They settled on really trying to work on a crisis of suicides that were happening in the middle school, and hit upon adapting the Sources of Strength program, which if you're not familiar with, I would encourage you to take a look at. It's a peer-based program for promotion of wellness amongst teens, actually started in tribal communities in the Dakotas. And that is being adapted and implemented in the Ortega Middle School with funding from the Colorado Health Foundation in Alamosa. And the group has very creatively created some wraparound community activities to engage students and community betterment activities as a part of this as well. So now I'm going to transition to Northeast Colorado, one of our other upstream communities, and their interest was again in trying to come up with ways to get awareness out. You'll see here the four main messages that mental, emotional, behavioral health problems are common. Everybody in the community can be affected by these. They can be prevented, and prevention and early help are available in your MEB box. They also did boxes, go figure. What was really interesting about the boxes here was the way that they did them. I'll show you pictures here in a moment. So they were interested in creating this locally tailored evidence-based curriculum that used a universal prevention approach, really trying to target youth and families across an age spectrum and create and disseminate age-specific MEB boxes. So they've started with a baby MEB box. And this really interesting story emerged in the group about how oftentimes when babies are born in rural communities, a memory box is something that families start. And so they developed this notion of a baby MEB box that could be given out when kids are born, when babies are born, that contain messages for the parents, things for the infant, all designed to educate and promote the mental health and well-being of those babies as they're growing. And that's currently being done right now, being distributed in Northeast Colorado, and evaluation to follow. So I'm going to stop there. Here's a picture from Alamosa and one of the events that our group co-sponsored, a community ice skate that we were a part of, and you could see the boxes there in the background. And our take-home message is that bringing community to the table can have big results. So I'm going to stop there, stop sharing my screen, and we'll open it up for questions. And folks want tabletop boxes. Okay, we'll figure out how we can do that. So if folks have questions or comments, I encourage you just to go ahead and unmute yourselves. I'm going to start off with a question for Dr. Johnson, just to get us warmed up here. I was really interested in the data that you presented from that Maryland survey, it not only the history of how imprisonment was a huge issue, but also how verbal abuse seemed to stand out in the data in terms of having a huge impact, particularly on suicidality. And I'm wondering how you've thought about the interconnections and interweaving of those ACEs issues. And we need to get you unmuted.
Thank you. Um, Cross that off your bingo cards. That's a great question and a good opportunity to talk more. So they asked about 5 ACEs and a host of emotional and behavioral problems. So then looking at all of these ACEs and all of these problems, it's clear that any ACE causes an increase in any problem, but what the specific pathways are is a lot less clear. And verbal abuse, strangely, didn't increase poor school performance all that much, but it was associated with other issues. So, why each specific ACE, leads to these specific increases for problems is probably idiosyncratic across people on some level, but also really, I'm not sure I understand, or that anybody does. The other challenge is that these were really, fairly crude ways of assessing ACEs. So what I have concerns about high school students evaluating what is caregiver verbal abuse. So does a parent or other adult in your home regularly swear at you, insult you, or put you down? I mean, the way it's worded, it's got a pretty high bar, but it's not entirely clear. The other one I was worried about in terms of measurement was, have you lived with anyone who was depressed, mentally ill, or suicidal? Again, I think a lot of folks could say yes when maybe a person doesn't reach a threshold. But overall, the general picture is that these things, that adversity really matters, and we need to focus a great deal on adversity as we think about emotional and behavioral problems.
Great, thanks. Yeah, fascinating stuff. Renee, I was really interested in your Momentum project, and curious how you're promoting that to the community, how the community is kind of helping to shape that, how moms find their way to your doorstep. Could you say a little bit more about that?
Yeah, thanks, Don, for asking. So COVID came and shifted everything we do because we were grassroots and on the ground working with pregnant women and moms, and COVID came and is shifting how we do prenatal care. So we just designed the Shiro program in response to COVID. It was timely. We wanted to make sure that women who it's when I think about pregnancy, depending if you're first, second, or third time mom, there are communities that are created in waiting rooms. And you'll be there, and there may be another woman who's about to deliver. There's another one who's there maybe for preconception. And this kind of community starts to happen where women communicate and they learn from each other. There are other places in the community, like grocery stores and libraries, where pregnant moms or women with children could actually come and create community and learn from each other. When we saw that wasn't happening anymore, it was, how can we incorporate technology to do that? And so we created this virtual community that we want to call eventually The Park, where pregnant women would be able to come across the estimated gestational ages and even postpartum and be able to create that community that we once got out in the real world in obstetric clinics and different places in the community. So right now we just submitted for Zuckerberg funding, and we're waiting to hear back from them. And then we're launching our pilot for this in a couple of weeks. And so we're just doing kind of snowball effect, social media, word of mouth for our first pregnancy pod. I think getting women involved wasn't the hard part. Finding BIPOC providers to lead the pregnancy pods was more of a challenge, those who had time and availability to actually do it, because it's a true commitment. We enroll women 12 to 14 weeks of estimated gestational age, depending on the last menstrual period. And also most of them should have had a confirmed ultrasound by that time. But we track with them from 12 to 14 weeks until they actually deliver. So it's a long-term commitment, and it becomes your actual pregnancy pod and family.
Very cool. All right, we've got a couple of more minutes, I think. Who else has a comment or a question?
Dr. Anthony, I was wondering, you guys were just discussing the Momentum Park. Is that like a national organization, or are you just focusing on your community right now in California?
So we will be.
Okay.
That's the goal. Momentum Park came about from our Healthy Families program, and I had an angel investor who was interested in addressing infant mortality. And when we met, I made it very clear, like, even though I do maternal and child health, my emphasis is on maternal. Like, I care about mamas, and if you get healthier mamas, you have healthier babies. And so much focus had been on infants with very little attention to mothers, so much that a study that we did when I was at University of Nebraska Medical Center, looking at the 3 options and why women chose either to proceed with their pregnancy, seek termination services, or proceed with an adoption. It was really interesting what some of the results were with women who chose terminations, in that people don't care about me, they just care about this baby. And so what we wanted to do when I spoke to this person was, if you want to address infant mortality, I feel from our perspective, the first goal would have to be focusing on the solution, which is improving the health and well-being of moms and their mothers, especially women of color. And they said, you're a disruptor, and we love disruptors in California. And so started from that perspective. And so now with Momentum Park, we're starting in California because of COVID, and I can't fly around as much as I used to, but the plan is to work with all our partners, whether it's City Match, AmChip, to be able to basically deploy programs like Shiro across the nation, and making sure that we introduce technology beyond just telemedicine and addressing the medical needs, but also the psychosocial and those social determinants of health needs that women need during and throughout their pregnancy. So just keep that name in mind, because 5 years from now, we'll be beyond California. You'll be like, I remember when I first heard about Momentum Park, and now look at what they're doing. And the last thing I'll say is that we wanted to make sure also that it was national. A lot of the funding, a lot of efforts have been international work and global work, which I care about all women and girls. But when I look at my own sisters and my aunts and my cousins, we really need to be focusing on what's happening here. As long as I have women who look like me, who we're bearing, and infant and maternal mortality looks like that in some of our developing nations, we definitely need those efforts to be here in the United States. And so Momentum Park is a national U.S. effort intervention nonprofit.
All right, well, we're at time. I want to thank all of our presenters. This was a great session. I hope all of our attendees have enjoyed it. Please keep your eyes out for the evaluations that will be coming to your inbox after the conference. We are really interested in your feedback. Stephanie, anything else from the conference standpoint?
No, I will share the Flipgrids with everyone again here in the chat, but that wraps everything up. Thanks to everyone.